Nisha Olivia, and I will be presenting headaches and epilepsy in primary healthcare. So
just make the audio a little bit louder.
Can you hear me now, Prof? Is it better?
It's not hard enough. If you don't mind just coming closer, and I think it should be okay.
And now, is it better?
Yeah, seems better. Thank you.
Okay, so we'll be starting with headaches. So according to Fraser and colleagues, headaches are one of the most common presenting complaints in the general practitioner's rooms. And according to the World Health Organization, headaches account for one of the top 10 reasons for causes of disability worldwide. Gardner and colleagues estimate that 46% of the adult population has an active headache disorder. Most headaches are classified by taking a history. Often physical examination has little to no contribution to the diagnosis. And while you are busy examining your patient and taking a history, it's important to ask about any precipitants. For example, if the patient is taking any oral contraception, if they are using caffeine and how much they are using per day, or how many cups of coffee and tea they're using per day. If the patient is using or abusing any substances or narcotics, if they've had any previous hospital admissions and any other associated symptoms, for example, any associated eye pain, which could lead to you investigating other causes of the headache. A nice thing for you to consider to discuss with your patient is for the patient to keep a headache diary and a calendar. We recommend that you record your daily headache symptoms for 1 to 2 months. You record the symptom of the headache and the patterns that it occurs. So you record the time of the headache, when the headache started, as well as if it gets better or worse over that duration, what makes the headache better or worse, if you take any medication, if there's any identifiable triggers that the patient may pick up, and if the headache is so severe and it contributes to a loss of activities of daily life or a loss of productivity, the patient should also note that down. And if the patient is currently menstruating, if it's a female, if they're menstruating or not, or if there are any other identifiable triggers that the patient thinks. Headache diaries and calendars can help you better identify causes, triggers, and how to diagnose the headache and better effectively treat it. So with regard to headaches, they are split into 3 big categories. According to the International Society of Headaches, headaches can be split up into primary headaches, which consists of migraines, tension headaches, and cluster headaches, as well as secondary headaches that can be due to trauma, vascular causes, and other miscellaneous causes. And the third type of group is any headache that occurs from painful cranial neuropathies or any other facial pains. So moving on to migraine. A migraine is a period of episodic pain that usually occurs unilaterally and has a throbbing or pulsating nature. It may occur with or without an aura. It may be associated with nausea, vomiting, photophobia, and phonophobia. It's also exacerbated by any exercise or any light movements such as walking upstairs or washing oneself or moving around. So in the primary healthcare setting, our first line treatment is Panado and Brufen at the maximum doses for pain. And to treat the nausea, we usually give metoclopramide or Maxolon up to 3 times a day or when needed. Prophylaxis, you can trial in tricyclic antidepressant like amitriptyline, which you can give 25 milligrams orally at night. But if amitriptyline is contraindicated, or if there is a poor response after 1 to 2 months, you may consider a beta blocker if that's available in your clinic. If you have tried first-line treatments and prophylaxis and the patient is still not responding to treatment, then it would be advisable to refer your patient to tertiary into a higher institute so that they could be treated with triptans or ergot alkaloids. I'm just quickly going to go over some of the diagnostic criteria for migraines with auras and without auras. So if your patient experiences a migraine with an aura, they should have at least 2 episodes that fulfill the following criteria. The aura should consist of at least one of the following, but important to note that they should have no motor weakness. So the patient may have fully reversible visual symptoms that have positive features or negative features. And positive features are things like flickering lights, spots, or lines. And negative features are things like a loss of vision. They can also have fully reversible sensory symptoms that include positive features, which is pins and needles, or negative features, which may be numbness, or they could have fully reversible dysphasic speech disturbances. They should also have two of the following homonymous visual symptoms that, or it can be unilateral, at least one aura symptom that develops gradually over 5 minutes, or different aura symptoms that occur in succession over 5 or more minutes. And each symptom should at least last 5 minutes, but no longer than an hour. And a headache that fulfills the criteria for migraine without aura, which I'll discuss in the next table, and it begins during the aura and follows the aura within an hour. And you need to make sure that the headache is not attributed to another cause. So the diagnostic criteria for migraine without aura is at least 5 episodes that last for about 72 hours, treated or unsuccessfully treated. And a headache that has at least 2 of the following characteristics. It's unilateral, pulsating, moderate or severe pain that is aggravated by routine physical activities such as walking or climbing stairs. And when the patient has the headache, they experience at least one of the following: nausea, vomiting, photophobia, or phonophobia. The headache is not attributed to another disorder. The next topic we'll be going over is tension headaches. And tension headaches is the most common type of headache that affects women more than men. And it's associated with a mild to moderate pressure, sometimes in a band-type distribution. And sometimes the patients will often describe that the pain starts at the back of the head and then becomes circumferential around the head. In the primary healthcare setting, the treatment for it is non-steroidal anti-inflammatories such as Panado and ibuprofen at their maximum doses, and as well as tricyclic antidepressants such as amitriptyline, 25 milligrams at night. Because tension headaches are frequently associated with some types of stress or triggers, you can talk to the patient about relaxation techniques, sleeping techniques, and if they would like to try, acupuncture and massage can provide some relief from pain. If the patient is not responding to the NSAIDs and the tricyclic antidepressants, or if they have any focal neurological signs associated with the tension headaches, or if there is poor response to the therapy, it's advisable to refer them to a next level of care. The diagnostic criteria for episodic tension type headaches. So tension type headaches can either be infrequent or frequent. And if they are infrequent, it is at least 10 episodes occurring fewer than 1 per day on average. And fulfilling the following criteria, it usually lasts half an hour to 7 days. And the headache has 2 of the following features. It can be bilateral, pressing, or tightening. Usually they are non-pulsating compared to migraine, and they are mild to moderate intensity. And important to note, whereas migraine is aggravated by routine physical activity, tension headaches are not aggravated by physical activity such as walking or climbing stairs. And they should also have no associated nausea or vomiting or photophobia and phonophobia. You need to ensure that the headache is also not attributed to another disorder. For frequent episodic tension type headaches, they are at least 10 episodes occurring on more than 1, but fewer than 15 days per month for at least 3 months, fulfilling all the criteria for an infrequent tension type headache. The third and final primary headache disorder we'll be discussing is cluster headaches. They're relatively rare, and they occur with episodes of excruciating pain in the orbital, temporal, or supraorbital areas, lasting 15 to 180 minutes and accompanied by autonomic symptoms. They usually have sudden onset, unilateral during a specific cluster, and it quickly reaches a climax. And they can occur in clusters during weeks to months So if a patient presents to you in your consultation or at the ED, you can try to abort the headache by using a trial of oxygen and seeing if that helps with the headache. Analgesias such as paracetamol and nonsteroidals are usually ineffective for this type of headache. However, some studies are showing that corticosteroids such as prednisone, given at a dose of 40 milligrams for 5 to 10 days, help abort the cluster headache. And when it's given at the dose of 40 milligrams for 5 to 10 days, this dose doesn't need to be tapered. Prophylaxis for cluster headaches includes a calcium channel blocker such as verapamil, if you have it available at your clinic, at about 40 to 80 milligrams twice a day, and to identify any triggers that can cause the cluster headaches. If you have tried the above and you are still having inadequate response, you can refer the patient to a higher level of care so that they can receive treatments. So the diagnostic criteria for cluster headache. So cluster headaches, to be noted, can be split into episodic cluster headaches and chronic cluster headaches, but the criteria includes at least 5 episodes fulfilling the following criteria. As I said, it's unilateral supraorbital temporal pain that lasts 15 to 100 minutes. And the headache is accompanied by at least one of the autonomic symptoms, such as conjunctival injection, lacrimation, nasal congestion, rhinorrhea, eyelid edema, forehead and facial swelling, miosis, ptosis, restlessness, or agitation. The headache episodes usually occur from 1 every other day to 8 per day, and is not attributable to another disorder. An episodic cluster headache fulfills all the above criteria, but they have at least 2 cluster periods lasting 7 days to a year, and are separated by pain-free remissions of more than 1 month. However, a chronic cluster headache has episodes recurring for more than 1 year without remission periods or lasting less than a month. So now moving on to secondary headaches. These are the headaches that are secondary to another cause that you should think of in your consultation. So secondary headaches can be due to vascular headaches such as transient ischemic attacks, hemorrhage, or vasculitis. Headaches can also be due to any other oral cavity or craniomandibular joint pain, such as dental caries, infections such as dental abscesses, temporomandibular joint disorders, or osteoarthritis of the temporomandibular joint. Headaches can also be due to things like trauma, such as head and neck trauma, substance withdrawals and medications, especially if your patient uses narcotics, they may be going through the withdrawal syndromes. If your patient uses caffeine, they may be having a caffeine headache because they didn't drink caffeine, or they may be drinking too much caffeine. And one of the side effects on medications is also a known headache. So if patients are abusing medications or taking too much medication, they can have a medication overuse headache. It's important to rule out any infections such as meningitis or bacterial sinusitis that can be cause of a secondary headache, any other psychiatric disorders, and neuralgia such as trigeminal neuralgia, glossopharyngeal and occipital neuralgias. And then some things that we sometimes forget are other types of headaches that can be due to a post-punctural headache, especially if your patient was recently admitted to hospital and had a lumbar puncture. If your patient is currently having any eye strain and is getting a headache from eye strain, sinusitis, and as I mentioned, medication overuse. So just some red flags that we should look out for when evaluating any acute headache. I'm not going to go through this table extensively, but the main things that we should look for, the main red flags are if the patient describes that the headache is the first or the worst headache of the patient's life. You need to ensure that it's not an infection, such as meningitis or any intracranial hemorrhage. Any focal neurological signs that are not a typical order, you need to think of vascular diseases such as an arteriovenous malformation, collagen vascular diseases, and any intracranial mass lesion. A headache that is triggered by cough or exertion or while engaged in sexual intercourse, you need to ensure that it's not a mass lesion and or a subarachnoid For headaches that have a change in personality, mental status, or level of consciousness, you want to rule out a CNS infection, make sure that it's not an intracerebral bleed or a mass lesion. For any neck stiffness or meningismus, you want to make sure that it's not a meningitis. The new onset of headache in pregnancy or postpartum, you want to make sure that it's not cranial sinus thrombosis, a carotid artery dissection, or pituitary apoplexy. And if the patient is older than 50 years old, you want to ensure that it's not a mass lesion or temporal arteritis. A headache associated with papilledema can allude you to a possible diagnosis of encephalitis, a MASH lesion, meningitis, or a pseudotumor. And if a headache occurs with the rapid onset of strenuous exercise, you need to be thinking of things like a carotid artery dissection or an intracranial bleed. And as you all know, the most common one is if a headache occurs with a sudden onset that is maximal intensity and occurs within seconds to minutes, like a thunderclap headache, you want to make sure that it's not in a subarachnoid hemorrhage. A headache with systemic illness, such as a fever or rash, you want to make sure that it's not a meningitis or encephalitis. And tenderness over the temporal artery, you want to make sure that it's not a temporal arteritis or polymyalgia. Headaches that have worsening patterns, you want to rule out a history of medication overuse, a mass lesion, or subdural hematoma. And a new headache in a patient with cancer, you want to make sure that it's not metastases. An HIV, you want to make sure that it's not an opportunistic infection or tumor. And in a patient with Lyme disease, which we don't see much of in South Africa, you want to make sure that it's not meningoencephalitis. On the right-hand side, you'll see all the types of tests that you need to undergo. Most of these tests require, or most of these red flags require neuroimaging and lumbar puncture. So for anybody who has a red flag, you may want to refer them to get a CT brain plus minus if you suspect need a lumbar puncture to a higher level of care. Okay, I will be moving on to epilepsy now.
Hi, it's Radia. I'm going to be presenting the section on epilepsy. Okay, so a little bit of background regarding epilepsy. Epilepsy is a chronic non-communicable disease of the brain that affects people of all ages. Around 50 million people worldwide have epilepsy, making it one of the most common neurological diseases globally. Nearly 80% of people with epilepsy live in low and middle income countries. And in terms of our South African demographic, epilepsy affects 1 in every 100 people in South Africa. Onto our definitions. Okay, so the WHO defines a seizure as excessive electrical discharges in a group of brain cells. Different parts of the brain can be the site of such discharges. One seizure, however, does not signify epilepsy. Up to 10% of people worldwide have at least one seizure during their lifetime. Epilepsy is defined as having 2 or more unprovoked seizures. Okay, so onto our etiology. So the etiology of seizures can be divided into the following: structural, genetic, infectious, metabolic, immune, and some unknown causes. And our seizure types and epilepsy types can be divided into focal, generalized, combined generalized, and focal. And then an unknown cause. We can move on to the rest of our table. Okay, so here's the seizure etiology according to age. In neonates, the common causes are perinatal hypoxia, metabolic disturbances, of which hypoglycemia is a common cause, as well as intracranial hemorrhage. In infants and children, common causes are febrile seizures, genetic disorders, as well as developmental disorders. In adolescents, some common causes are infection, trauma, genetic disorders, and brain tumors. And then in young adults, our common causes are trauma, alcohol withdrawal, illicit drug use, as well as brain tumors. And in older adults greater than 35 years, some common causes are cerebrovascular disease, brain tumors, alcohol withdrawal, metabolic disorders, and Alzheimer's disease. Okay, so on to the classification of our types of seizures. So seizures are divided into focal and generalized seizures. So in terms of focal seizures, our most factor is whether there's impaired consciousness, or known as simple partial. In this seizure, the seizure occurs on one side of the body without loss of consciousness. Some symptoms may include sensory, autonomic, or psychic effects. And then we have focal impaired consciousness, which is also previously known as complex partial. So there's a complete partial seizure, often preceded by a simple partial seizure, but is associated with altered awareness or loss of consciousness. And then in terms of our generalized seizures, you have either a generalized motor seizure or a generalized non-motor seizure. So with the generalized motor seizure, it is divided into the three following types. Generalized tonic-clonic, which is a loss of consciousness preceded by a brief stiff phase followed by jerking of all the limbs. Tonic, which is one or more limbs become stiff without any jerking. And myoclonic, which is brief, usually generalized jerks with retained awareness. And then we have generalized non-motor seizures, which is known as our absence seizures, which occurs in childhood. It's a sudden cessation of activity followed by a blank stare. There's usually no twitching involved, and some children will smack their lips. Okay, so here is the diagnostic criteria. One of the most important parts of the diagnostic criteria is the history. So we usually obtain the history from the person who witnessed the seizure. It's very, very important to differentiate between syncope and a seizure. We have a table later on which will clarify this. So in the history, we're looking for these important facts. Was there an aura or warning sign? We're going to ask the patient's caregiver to describe the seizure step by step. Is the patient conscious during the seizure? How long do the seizures last? What does the patient experience after the seizure? And is there a history of incontinence or tongue biting? And if possible, we'd ask the family member to please take a video recording if possible. In terms of our examination, first we'd obviously do all of our ABCs, and then we'd go into our neurological examination. And then we'd also look for some dermatological manifestations of epileptic syndromes, such as ash leaf spots, Sjegren patches, facial angiofibromas, and ungual fibromas, which are commonly seen in tuberous sclerosis. And in terms of our special investigations, we do a CT brain to exclude any structural causes, and EEG, blood. So very important in our setting is breakthrough seizures. So we do serum levels of anti-epileptic drugs, as well as a lumbar puncture if meningitis or encephalitis is suspected. Okay, so on to our diff diagnosis. In terms of epileptic seizure versus syncope. So with syncope, the patients are usually in the upright position. And in terms of our tonic-clonic seizures, it can occur in any position. In terms of the facial color, patients that experience syncope are usually pale, whereas patients with an epileptic attack will present with cyanosis. In terms of the onset, syncope has a gradual onset induced by dizziness or blurring of vision. And our tonic-clonic seizures have a sudden onset that can be preceded by an aura, such as a simple partial seizure. In terms of twitchings, you hardly see twitchings during syncope, and there's always twitching involved in our tonic-clonic seizures. In terms of enuresis, it's rarely seen during syncope and it's very often seen with tonic-clonic seizures. There's no tongue biting seen during syncope and it's present during tonic-clonic seizures. In terms of the duration, syncope usually lasts for about 10 to 20 seconds, whereas a seizure lasts for a few minutes. With syncope, there's no post-ictal confusion, and this is present during tonic-clonic seizures. And in terms of perspiration, there is pronounced perspiration during syncope, and it's not typical during tonic-clonic seizures. Okay, so our differential diagnosis continued. So on the diff for seizures would be fever, your febrile seizures, meningitis, encephalitis, and a brain abscess, sepsis, as well as tetanus, birth asphyxia, head trauma, metabolic, which is very important. So hyponatremia, hyperbilirubinemia, DKA, and hypoxia, as well as toxins, certain drugs, medication, and alcohol and substance withdrawal. Strokes and TIAs can also present with seizures, syncope and arrhythmias, a brain tumor or mass, as well as migraine, and lastly, neonatal abstinence syndrome. Okay, so in terms of our management, some general rules. A single medication is always best. Combination therapy should only be initiated by a specialist. The recommended doses are general guides that will be effective in most patients. Some patients may need much higher or lower doses. Doses should be increased at 2 weekly intervals only. In patients receiving any anticonvulsants, therapeutic drug monitoring may be useful to confirm suspected non-adherence or diagnosed toxicity in a symptomatic patient. Therapeutic drug monitoring should be done in patients receiving higher than usual doses of phenytoin. Okay, so here are the treatment guidelines, our South African guidelines taken from our EML. For generalized tonic-clonic seizures, the aim is to use monotherapy, so a single anticonvulsant, progressively increasing the dose until the seizures are controlled or clinically important side effects occur. So our first line is lamotrigine, orally, which is doctor initiated. So you'd start with 25 milligrams daily for 2 weeks, and then you'd adjust the dose to 50 milligrams daily for 2 weeks. Thereafter, you'd increase the dose by 50 milligrams every 2 weeks according to the response. The usual maintenance dose is 100 to 200 milligrams daily as a single dose or divided doses. Second line is carbamazepine, which is also given orally. You'd start with 100 milligrams 12 hourly, and then increase by 100 to 200 milligrams per day at weekly intervals. So the guidelines state that if the patients aren't controlled on either of these anti-epileptic drugs, then you can initiate the patient on Epilim. So the reason why Lamictal is stated as first line in the guidelines is because Lamictal has very few drug interactions, and it's also very safe in women of childbearing age, as well as patients on antiretroviral therapy. Okay, so here is our emergency management. So status epilepticus is a medical emergency. It's defined as a series of seizures following one another lasting 30 minutes with no periods of recovery or consciousness. The management is as follows. Firstly, your ABCDEs, give oxygen if needed, establish IV access, and check vitals every 15 minutes. Very important, don't forget the glucose. Then you'd abort the seizure with a benzodiazepine. So we could give diazepam 10 milligrams IVI slowly. The IM injection works slower and is more erratic. You could give lorazepam 4 to 8 milligrams IVI or IMI. You could load with phenytoin 1.2 grams IVI, and then transfer the patient once stable. Okay, so here's some important criteria for referral. We'd refer all patients with new onset epilepsy for further investigation, such as CT scans, if you think that that is necessary. Patients with seizures other than generalized tonic-clonic seizures, including absence seizures. Increased numbers of seizures despite attempts to address adherence issues or changes in the seizure type. Patients who have been seizure-free on therapy for more than 2 years to review therapy and consideration of stopping treatment. Pregnancy, women of childbearing potential who are on valproic acid for switch to a less teratogenic medicine. any development of neurological signs and symptoms, adverse medicine reactions or suspected toxicity in children, if uncontrolled on monotherapy, once patient has been shown to be adherent on monotherapy at the optimal dose. Okay, and here are our references. Thank you.
Thank you very much, Radia and team, Tasneem as well. So I just want to quickly mention a few things. Whenever you, in both these settings, both headaches and epilepsy, it's important for you to think about what's common. So tension headaches are much more common than migraine. We tend to think of migraine much more commonly than we should. So just have a sense of what is the sort of epidemiology of the disease when you're sitting and thinking differential diagnosis through. Think of a tension headache more often than you do of a migraine. It's the same comes with a patient in any of the other situations. So for example, when you're looking at situations of epilepsy, tonic-clonic is very common. You also need to think about in both headaches and in epilepsy, secondary causes very much more commonly than you think about. So absence, again, seizures, not very common. It's something that you'd find yourself being confused about whether it is even a seizure. Very odd story, so I'm sure that you're familiar with it. But in managing in primary care, understanding what is common is very, very important. So just review some of the slides and think about how you approach in primary care using the commonness of disease and conditions in terms of how you navigate what you really need to know and what's less important. Thank you, Radia, and thank you to Tasneem for the presentation.